A final set of processes important for adoption in value-based care relates to care coordination. We've mentioned care coordination frequently in the context of making sure that when care crosses the continuum from primary care provider to specialist to hospital and hospitalist to rehabilitative care to nursing home and or home health, the needs of the patient are known to and supported by all providers in the continuum. The National Quality Forum defines care coordination as the function that helps ensure that the patient's needs and preferences for health services and information sharing across people, functions, and sites are met over time. While accomplishing care coordination is not easy, it is also not easy to distinguish roles in care coordination and other similar functions. The following distinctions seem to be the most common with respect to these different roles. First is the care coordinator, who is a person who takes individualized action in support of care coordination, which we just defined, for a patient, including taking responsibility for developing a care plan with the patient, arranging and tracking appointments, educating patients, and coordinating other aspects of their well-being. A care coordinator may be a clinical or non-clinical professional, and roles may include, in addition to care coordination, case management, coaching, and advocacy. Some care coordinators are referred to as referral coordinators. Care coordinators generally work within a given setting, such as a hospital or large clinic. The patient navigator and patient advocate are closely related roles. A patient navigator is a person whose role can be similar to a care coordinator, but who focuses more on coordinating care across provider settings, and who may help arrange for financial support and helps a patient navigate through the complex healthcare system to overcome barriers in accessing quality care and treatment. On the other hand, a patient advocate is more focused on serving as a patient coach when a medical crisis occurs, in contrast to a care coach or health coach who focuses on a person and wellness. Patient navigators and patient coaches may be someone hired directly by a patient or patient's family or supplied by a large provider. A care manager is typically a nurse who can work independently with patients to set management goals, triage health issues, and help manage certain chronic diseases. Care management is an intensive focus on a subset of patients who are acutely ill or have many chronic illnesses. Sometimes this person is referred to as a health coach or care coach. Care managers often work for health plans, but increasingly for large health systems to help manage costs for high-risk patients. Another role, in contrast to care manager, is case manager, who is typically a social worker, behavioral health specialist, or nurse whose role is broader than case manager, addressing social determinants of health and assisting patients with housing, domestic violence, food assistance, etc. A case manager may be employed by a health plan provider and often a social service agency in a community. Now, disease management should be contracted with care coordination and care management. Disease management is a program in which physicians, nurses, pharmacists, dietitians, respiratory therapists, psychologists, and others are focused on improving the health of persons with specific chronic conditions and reducing healthcare service use and costs associated with avoidable complications, such as emergency room visits and hospitalizations. These programs are typically found in commercial health plans, managed care plans and sponsored health plans, provider-sponsored health plans, CMS and some state Medicaid programs, and larger employer settings. It is important to note that all care coordination, care management, case management, and disease management, each with varying roles associated with these functions, benefit from risk stratification to target patients with high and emerging risk. Coordination and management support are needed in all cases. High impact changes are sought and transformative change to improve value is the goal. So now let's look at new and renewed models of care for value-based care. Some call it disruptive innovation, others refer to Health 2.0 or 3.0. Whatever moniker you wish to apply, in value-based care, providers especially, but also health plans, pharmaceutical manufacturers and vendors of medical devices and health information technology, and patients are making changes in how care is delivered and consumed that ensures a viable healthcare marketplace in which the triple aim of healthcare, quality, cost, and experience of care, are all improved. Some of the models of care that are new or are garnering renewed interest are listed here. Retail clinics, patient-centered medical home, concierge medicine and direct care, home-based diagnostics, urgent care, virtual care, telehealth, and hospital in the home. For example, what was once much maligned, many providers and even CMS are now looking to retail clinics as a means to extend a primary care provider's reach at much lower cost and in a much more timely manner. Similarly, patient-centered medical home is a concept receiving renewed attention. While retail clinics are limited in scope of services and patient-centered medical homes are not, both have two things in common. First, they both utilize physician extenders, nurse practitioners and other advanced practice nurses or physician assistants, to remove the burden from physicians for treating common acute conditions at the same level or better than the quality of care in most ambulatory or emergency department settings. Second, retail clinics and patient-centered medical homes receive much higher marks on use of health information technology, quality indicators, lowering cost, and improving patient satisfaction. Both remove the burden of delivering mundane care on primary care providers, so they may focus more on the challenging patient and coordinating their care. Concierge medicine, in which patients pay a retainer fee for access to personalized care while providers still bill health plans for services, and direct care, in which patients forego insurance coverage and pay all out-of-pocket costs for primary care, are two more ways providers are responding to consumer demands for improved access to care at lower cost, and as a result, contributing to generally healthier patients because they are then more engaged and more empowered to reduce their own costs of care. Providers also find that they can maintain a more manageable work schedule, have less paperwork, and are happier interacting with their patients with these structures, which are essentially alternative forms of payment for care rather than delivery of care. Coupled with home-based diagnostics, the timeliness and cost of care can be further reduced. Pregnancy tests, HIV and Hep C diagnostics, blood glucose monitors have been around for a while. But many more types of tests are coming to market that are far cheaper for patients and reduce overhead and marginal cost of office visits for providers. Urgent care centers are also not new, but much like the retail clinics, they are filling a niche that in this case relieves emergency departments from treating anything but for those who truly are in an emergency health situation. Similarly, virtual care through electronic communications is shifting annual exams to home via telehealth, using e-visits for aftercare and question answering, and managing certain chronic diseases through remote monitoring. It is estimated that over a third of customers are interested in using virtual care today, and this is anticipated to grow rapidly with changing demographics. One of the latest innovations is hospital in the home, where despite concerns from some health plans and physicians, who we must remember tend to be very conservative and risk-averse, it is being found that not only are costs lowered, but the risk of hospital-acquired infections is lowered and recovery is speedier, and patients really like to be in their own homes. So what is the future of value-based care? Many have raised concerns that particularly under a new administration, value-based care will be short-lived. Despite the administration's mixed signals and only modest gains so far, several initiatives are renewing their leases, so to speak. Perhaps the bundled payments for care improvement initiative is the most visible, but so too is CMS demonstrating that they not only are not giving up, but going full speed ahead with moving toward increased sharing of risk, including getting the U.S. Department of Health and Human Services Office of Inspector General to approve a proposed risk-sharing initiative, albeit with guardrails. Certainly no one can predict the future with 100% accuracy, but many have suggested that, as illustrated on this slide using a genie rising from a bottle encased within a crystal ball, the genie is out of the bottle when it comes to many of the innovations we have already seen. From the high tech we just talked about to consumers not only wanting such innovation, but also wanting to take more control over their own health and even payment for health. Value-based care will undoubtedly look different 5 or 10 years from now, but the concept of value to improve the quality of care in the U.S., lower the economic burden, and address the needs and desires of newer generations of patients and consumers will remain and is expected to grow. What can you do to help? First, I believe it is essential to keep on top of what is going on by regularly perusing the literature, especially on topics which not only interest you but challenge you. Second, keep an open mind and help others around you do the same. Change is never easy, and we've seen that change is especially challenging for physicians and other clinicians. Taking the lead in any small way can help others adopt and adapt to change. Third, take full advantage of technology that supports generation of business and clinical intelligence that can aid decision making for all aspects of value. If you are not in IT, health information management, or health informatics, seek out those who can help you. With the pace of change in health IT, we all need help along the way. Finally, as collaboration, creativity, and accountability are hallmarks of the transformation to value-based care, practice these attributes in everything you do. Work with others. Never put down a new idea, but look for ways to ensure the new idea is trustworthy and directed to quality, cost, and experience of care improvements. As this is our last lecture in this MOOC, and close with the references as usual, I say goodbye only with the hope that the course has been of interest to you and has stimulated the learning person in us all. Don't forget to take the last assessment, and the very best of luck to you.